Medical Specialists Associates, making medical education more accessible.
Hi, my name is Christopher Viskopoulos of Medical Specialists Associates, and thanks for joining me for this important topic of APRV ventilation for COVID-19 respiratory failure management. Now, this particular talk is really largely centered around the protocol that we've developed as a medical group for how to manage and implement APRV ventilation. And this particular protocol can be found on our website for you to be able to download. I do need to mention here that it's important to note that this particular protocol was created in a step-by-step guide for how to implement APRV. And we did that specifically just in case if you are either not familiar with APRV ventilation, or it's been a long time since you've used it, or if you need to introduce this to your respiratory therapy department where they need a step-by-step guide upon how to implement or manage APRV. This protocol is perfect for that particular aim. So with that in mind, let's turn here now to our talk, and we'll cover a bit more of an introduction about APRV, and then we'll talk specifically why APRV at this time, and there'll be some important reasons why we're introducing it at this time during the latest surge in the COVID pandemic and everything that we've learned in all the prior surges about respiratory and ventilatory management. And then, of course, we'll talk about indications and we'll review our protocol in detail. So why APRV at this time? Well, if you're like most of us, we've been managing our COVID-19 respiratory failure patients up until this time, largely by following the society guidelines and the national guidelines for how to manage this particular type of respiratory failure, which means that we've been following ARDSNet, where we've strictly made sure that we didn't have any stretch injury by making sure that our patients were compliant with the ventilator and getting between 4 and 8 cc's per kilogram. But what has been some of the difficulties that we've seen with this? Well, some of the difficulties that we've seen is that our patients have required large amounts of sedation, actually more sedation than we've ever seen before in the management of respiratory failure patients. And that excess sedation has created difficulties, which we'll review in a paper in just a little bit. Now, alternatively, instead of maybe excess sedation, maybe we've used more paralysis than we normally have. And of course, that in and of itself creates difficulties by having a higher incidence of things such as critical illness myopathy and further deconditioning, which can also lead to increased mortality. But also, in our use of heavier paralysis and sedation, we've missed the ability to do neurological exams in this patient population. And this is important because COVID-19 does represent a prothrombotic condition. And it's important that we're able to screen our patients while they're undergoing ventilatory management for things such as embolic or hemorrhagic strokes. But again, our current management to date on ARDSNet protocol has limited that because largely of the large sedation that we've used. So why then APRV? And then why specific to the COVID-19 surge? Well, again, because we're having to use higher amounts of sedation. And so what APRV represents is a spontaneous mode of ventilation. And so because we're allowing our patients to breathe spontaneously, we can have a reduction or even an elimination in sedation. I manage approximately 10% of my APRV patients on absolutely no sedation whatsoever, and they're comfortable and they're fine. We also need less analgesia requirements because it's less aggravating to the patients. And we have better ventilator synchrony when the patients are allowed to breathe spontaneously. We're not controlling every breath of theirs as we do with ARDSNet. And then, of course, since patients are breathing spontaneously, we have no need for paralysis. And I'll review with you how to have lung protective strategies on APRV. I commonly get questions about, well, how do I guarantee lung protection strategies on APRV? Or it's not possible to have lung protection strategies on APRV. And that's not really quite accurate. And I'll review with you how to set up the ventilator settings to enable lung protection in mind. And then, of course, the advantages of APRV here is that with little to no sedation on board, we're able to have neurological exams where patients are able to move all their extremities. And certainly with them being able to move all their extremities, we'll be able to, at the minimum, pick up things such as focal neurological deficits if they're present, and or the ability maybe to pick up things such as non-convulsive seizures if patients really kind of aren't waking up as we think that they should. So this is what I've been referring to here in reference to some of the excess sedation. So this was an interesting paper that was recently published in Critical Care Medicine, and it came out of the Boston area hospitals, in which they test the hypothesis that individuals with the COVID-19 acute respiratory distress syndrome were at higher risk of inpatient mortality due to coma from higher amounts of sedation as compared to patients that were matched for acute respiratory distress syndrome not with COVID-19. And what these particular authors did here is that they were able to match 114 COVID-19 patients with 228 non-COVID-19 acute respiratory failure patients. And what they found here was that the COVID-19 patient population had a in-hospital mortality of 48.3 as compared to 31.6%. And what they found was that the hypnotic agent dose was much higher, 51.3% as compared to 17.1% in the COVID-19 respiratory failure patient. And again, they had to use these higher dosages of sedation in order to bring about ventilator compliance. And what they found here was that the hypnotic agent dose was associated with coma. Individuals were having RASs of -3, -4, -5. They were deeply sedated. And really, the most important thing that they found here was that coma was associated with in-hospital mortality, an odds ratio of 4.84, so almost 6 times higher in the COVID-19 respiratory failure patients. What this is really telling us right here is that in us trying our best to follow the national guidelines of implementing ARDSNet criteria in many of our COVID-19 patients, we were forced to heavily sedate. But that heavy sedation in and of itself carries increased mortality risk. And so we found ourselves really in a bind there. And that's where APRV really comes into play. And so let's take a closer look here at APRV and why it could be an answer for some of these patients. So just broad indications for APRV here, really any acute hypoxic respiratory failure patient, any ARDS or acute lung injury patient. Specifically, what we're really presenting here is ARDS due to COVID-19, but you can also use it for really any diffuse pneumonia patient. And so it's important to keep in mind that this is just another tool. We're not saying here that APRV is the be-all and end-all, and it should be used on every single COVID-19 respiratory failure patient. But this is an important tool that you can consider implementing in your facility for the right patient. And really what you'll see here is that RT education is key. And I'll go one step further and I'll say, even though it's not listed here, nurse education is key here, because when you change to APRV and you're allowing patients to breathe spontaneously, sedation regimens change. Really, you're trying to limit sedation so that they breathe. So it's important that you educate the nurses in this regard. And again, it's also important, obviously, to educate our respiratory therapists so they can help guide this particular treatment strategy in patients and help us manage these particular patients. And so let's here take a look now here at our airway pressure release ventilation protocol. And so important notes, this mode is relatively contraindicated in severe COPD patients and severe asthmatics. Now, I mentioned that because what you're going to notice here is that we set something called the T low, which is where patients breathe. And I say relatively contraindicated because you can still use APRV in these particular patients. But as you learn more about APRV during the course of this talk, you'll see that you likely would have to have a much longer T low time to allow these patients to have a longer exhalation time. And that's something that I'm sure that you're familiar with in your normal COD patient, to where they just need a longer exhalation time because they have decreased recoil of their lungs due to that decreased elastic tissue that they have. Now, this particular protocol of APRV presents APRV as a spontaneous breathing mode of ventilation. And this is what we're defining APRV as in this particular talk. Now, I'll note that some practitioners might incorporate what they call APRV management and not allowing patients to breathe. And really what I would call that more as a distinction is inverse ratio breathing between the I and E, the inverse ratio, and not really APRV, at least as we're classifying it here. So moving on here, what I thought I would do here is I thought I would first show a video about how we set up APRV, and then I'll go over step by step what each of these points means. Now, on our same patient here, let me walk you through how we would set up APRV. So in our Covidien Puritan Bennett 980 series ventilator that you can see here, first thing we'll do is we'll click the bottom button down here to bring up our vent modes. We would go to our event modes and go over, and under mode, we find bilevel here. And so we would click on bilevel. When we click on bilevel, this is the panel here that brings up. And so for our particular patient, it's important to have the basics, which is having down ideal body weight, but now to set our frequency of breaths. And so for this particular patient, we're going to set 10 breaths per minute, meaning that we're going to have a 6-second time interval. And so one of the next things we'll set here is our P high by pushing here. And here we're going to set our P low to 0 or 5. And here is where we'll set our time. And we are going to recommend that you just set the T low and then you lock the T low down here. Notice what you can do down here is you can toggle between T low and T high and lock one or the other. But really what we want to do is we want to figure out our T low. And that T low, maybe you can start at 0.5 or 0.4 or so, but what you're going to be doing is targeting 6 to 8 cc's per kilo of breaths with the drop to maintain that lung protective stretch strategy. And so if you're not familiar with this, up top here, what we can set is our minute ventilation and then our cc's per kilo here. What you do is you just double tap any of these, and in double tapping them, what it brings up is this particular panel, and then you can choose what would be on top. And so for here, we chose to have the cc's per kilo here as a nice additional measure of safety. So now I'm going to go back into our settings here, and we lock the T low. This is also very nice too, because as we talk about dropping and stretching, we have locked the T low, so we will lock that tidal volume ratio there. Next, I'm going to talk about adding tube compensation. And so here, we can click this button here, tube compensation, and then what brings up is the type of tube in. This individual has a 7.5 ET tube, and by clicking that, then they have automatic tube compensation. Now, if your machine doesn't have tube compensation, what you can consider adding is PSV here, and in which maybe you would add a 5 pressure support maximum. But I'm going to go back to tube compensation there. And then we would usually set our FiO2 to 100% to start, and then rapidly titrate down. So here I'm going to accept all, and we come back to the settings that you saw previously. So I thought it would be easier there to start with that particular video and then to break down some of the things in more detail as to how I presented them. So the first thing I had mentioned there is that consider starting here with a 6-second time interval for breaths. That would be a respiratory rate, of course, of 10. And so the first thing we can set here is our P high. And we usually set P high approximately 30. Now, I do note that sometimes higher pressures are needed, and often higher pressures are needed in those patients who are morbidly obese. If you happen to be one of the centers that happens to have an esophageal balloon and you're able to measure transpulmonary pressures, and you have more, confidence that if you have higher PEEPs, you're able to have lung protective strategies against barotrauma because you know that they have a transpulmonary pressure such as you can have a higher PEEP, then that would be okay. But it's also reasonable to assume that many of these COVID-19 patients that we're taking have very large BMIs, 35, 40, 45 or so. And so it's not unexpected if they needed a higher pressure because of their body habitus. And so largely here we're saying a P high of 30 and FiO2 of 100% to start off in a normal weight patient, and perhaps maybe considering you can go to the P high of 30, or you might want to consider just jumping to a higher pressure such as 35 in the morbidly obese population. So now next we're going to set the P low. So now normally I set the P low at 0 because I'm comfortable in setting my T low and my drop. However, if you are not as familiar with APRV, you might want to consider first starting off with a P low of 5. And this will make sense just in just a little bit when I talk more about the T low. Now, largely what we're going to do is when we set our P high of 30 and then say our P low of 5 or 0, the patient's going to go along for approximately 5.6 seconds or so on that 6-second cycle, and approximately going to spend time dropping down 0.4 seconds. Now, if we choose our T low drop time appropriately, it's very important that that patient never reaches the complete bottom of that respiratory cycle. What I mean by bottom is that they exhale their full amount of vital capacity, and they actually are at risk of having some atelectasis at the time. What is so concerning at that time is because if they lost all that air and some of their alveoli collapsed, and then they have that large P30 or P35 pressure come back in, then those alveoli could reopen again, and you can have atelic trauma or a shear injury in those alveoli. Now, if you choose that T low appropriately, you never reach that bottom, so you don't have to worry about it. But again, the reason why we mentioned considering a P low here of 5 is that if you don't have as much familiarity, there's no problem in starting off at a P low of 5, just to give yourself a little buffer to where it's not really possible for someone to drop all the way and to close those particular alveoli. And so here I just talk about, the overarching goal again is to set your initial settings to target tidal volume of 4 to 8 cc's. And really what I mean there is that how you're adjusting your T low from somewhere from, say, a 0.2, maybe all the way up in extreme cases, the COPD patients, otherwise a 0.8, but commonly between 0.2 and 0.5 is you're adjusting that really to those 4 to 8 cc's per kilo drop. And if you maintain somewhere within that 4 to 8 cc's per kilo, you're not likely to drop all the way down. And in essence, you'll be lung protected from both the atelic trauma as well as stretch injury in those particular patients. So now let's talk about T high. Now, normally I recommend not to adjust the T high. And what I mean by that is that when you put someone on a 6-second time interval, as you saw in the video, if you lock their T low, now you're locking their T low to that 4 to 8 cc's per kilo. And though it is in theory possible that as you're treating someone over time, their lung compliance changes and you need to readjust the T low, it doesn't happen often. And so if you just lock the T low, then what you're able to do, and you'll see in later videos, is you're just able to turn down the respiratory rate when you drop and stretch, the concept that I'll introduce in a little bit, and that'll automatically adjust the T high time. Now, let's say if you happen to have a ventilator that doesn't allow you to lock the T low and you have to set each value independently. Well, if that happens, at least as initial settings, perhaps maybe you'll set the T high somewhere around 0.6 or so. But really, you're going to come back to the T high because you're going to first adjust that T low and then see what it is with that 4 to 8 cc's per kilo drop, and then come back and then again set that T low appropriately if your ventilator forces you to do that. And so you can initially set the T low here to maybe 0.5 or so. Again, normal range is between 0.2 and 0.8. But again, you're really largely going to set that T low based upon that drop of 4 to 8 cc's per kilo. And so again, really what you're doing is you're ensuring that you maintain your mean airway pressures so that you don't have excessive exhalation as to not occur that atalic trauma, which we discussed. Our next slide here. So we'll start off with FiO2 at 100%. And this is really largely a lung recruitment, particular type of ventilation. And so what we want to do is we want time for those higher pressures to take effect. As we know from ARDSNet and otherwise, that when we change the PEEP, it really could take up to 24 hours for full lung recruitment. And so we want that lung recruitment to take place. And so the first thing we're going to do is we're going to titrate down the FiO2 as quickly as possible. And you'll see here that you can titrate that FiO2 down to a target of 60, or if you want down to 50% before turning your attention to the pressure as you begin to drop and stretch. And so since I mentioned here now pressures of this being an open lung strategy or a recruitment strategy, there are really two aspects here that enable recruitment. The first are those high pressures at say P30 or P35 in which someone maintains, for say 5.6 seconds or so, where they're recruiting their lung. But the other important mechanism is spontaneous breathing. Because recall, in positive pressure breathing on the ventilator, air tends to go to the area of least resistance. And that happens to be alveoli that are already open. They have a tendency not go to the alveoli that are closed. But negative pressure breathing or spontaneous breathing, as they're doing in APRV, well, air tends to go to the alveoli that are closed. Because again, someone's diaphragm's dropping down, chest walls expanding out, it's putting more traction on those peripheral alveoli and opening them up. So by both spontaneous breathing and the high pressures, you get incredible recruitment of lung tissue. And that's why you can see individuals' PF ratios change dramatically in a short period of time. And you should be able to decrease your FiO2 rather quickly. And so here, start decreasing your FiO2 as quickly as possible. So here, as you saw in our particular video, if you have tube compensation, it's important to put tube compensation on so at least the patient's not breathing against the resistance of the tube. If you don't have tube compensation, we recommend here to add a pressure support of 5. However, it's important to know what a pressure support of 5 means for your particular ventilator. A pressure support of 5 could literally mean just dialing in 5. However, for your particular ventilator, you might say if you're on a P high of 30, you might actually have to dial in your pressure support to 35. And the reason being is because you're still only getting a pressure support of 5, but for your particular ventilator, you need to program 35 because it's 5 above the 30 that you set for your P high. So it's important to make that distinction if you have a ventilator to where you need to program in pressure support. So now let's just review this snapshot right here and just go over again some of the things that I mentioned. And so one of the first things you're going to do is dial in your respiratory rate of 10, and that's going to give you your 6-second time interval. You're going to start off, say this is a non-obese patient at 30 or possibly maybe 35 in some of your morbidly obese patients. You can set your P low here to 0 or 5 as we discussed. Here we set our T low to 0.5, but we did that because we're really targeting up here our 4 to 8 cc's per kilo. If this patient, were having excess tidal volumes at 0.5, we might go all the way down to 0.2. Again, watching this up here. So we put tube compensation on this patient right here. And normally you would start the patient off at 100% FiO2. I happened to take this picture when the patient was being weaned down. And so here they're on 80%. Up here, it's important to note that you could have such metrics to watch, such as total minute ventilation. You could have spontaneous minute ventilation only. And of course, here you can see the cc's per kilo. And important to show the respiratory rate up here, right? Because up here, you can see that the patient is having the control breaths here, but most importantly, they're having all these smaller breaths up here. And this is important. This is the spontaneous breathing that we want. And again, you might get questions such as, when you're on a P30, the pressures are so high up here, what are those small breaths really doing? They're not really doing that much. They might not be doing that much in terms of ventilation at that particular time, but what they are doing something is for recruitment, opening up more of the alveoli so you have more of that ventilation perfusion matching, which we all want. Later on, as you're decreasing your P30 say all the way down to a P high of 20 or so, those breaths are going to become bigger and they're going to contribute more to ventilation at that time. So now let's move on here and, initial settings goal. And so what we're going to do is we're going to allow an acidemia up to 7.15. This is really specific right here to COVID-19. Prior to this, we really all tolerated up to 7.2, but here we're allowing more extremes in terms of values because, again, ventilator management is more difficult in this patient population. We can allow hypercarbia, again, as long as the pH is above 7.15. And we can target a PaO2 of 55 to 80. So again, prior maybe to COVID-19, we allowed PaO2s of 60 to 80. But again, we're dropping this number down to 55 because these patients tolerate hypoxemia better. And again, we're trying to be more aggressive in lung protection and otherwise by allowing the numbers to be slightly lower. It's important to note that a PaO2 of 55 correlates to approximately a pulse ox of 85 if the pulse ox had a 1-to-1 correlation. Now, of course, since the pulse ox is not a direct measure of oxygen in the blood because it uses ultraviolet, infrared light, ultraviolet light to detect hemoglobin concentration through an algorithm, it is not as accurate as blood gases. And so there's a lot of things that can come in play. So we tend to rely more on blood gases and to first get one blood gas and see what it is and see how well it correlates to pulse oximetry. Now, if you happen to be a center that doesn't get as many blood gases maybe as we do, and you rely more on pulse oximetry, perhaps maybe targeting a pulse oximetry range between 88 and 93 might be something more reasonable for you. So how do we deal with certain difficulties on APRV? Well, the first one is what if you had hypoxemia? Really that hypoxemia, you are oxygenating during T high. And so one of the first things you can do is consider increasing T high within, again, the range of 5.2 to 5.8. Again, as long as you're lung protected with your T low times with the amount of cc's per kilo. And you normally would increase your T high time by 0.1. Here, I'll just kind of pause for a moment and I'll just say that, 0.1 might not sound like a lot when you're adjusting a T low or a T high, but these small changes provide huge results on APRV. So don't be not impressed with the small 0.1 value. It really does mean a lot when you make these changes. And then since it's really the pressure that is opening up someone's lungs as one of the main mechanisms, you could, if you're not at a P high of 30, you can consider going to 35, and you can increase by 1 to 2 up to 35. However, again, as discussed earlier, you might have a super morbid obese patient and you might have to go above 35 in a particular patient. If you do, I recommend consulting with your intensivist and just making sure that this is a strategy that you think would be lung protective based upon the patient's particular body habitus. So what about respiratory acidosis? Again, you could adjust that T low within the range of 0.2 and 0.8. Say if your patient was only maybe getting 4 cc's per kilo, you might want to increase the T low time a little bit. The target may be closer to 6 to 8 cc's to give them slightly bigger tidal volumes. Again, you increase that T low by 0.1 intervals. Now, in theory, you could change the P low to 0 if you're on 5. And what I mean by that is you might have set your particular P low to 5, and 5 was more appropriate for you because, say, that patient was dropping and they were cutting off at 5 because maybe you are less familiar with APRV and you're just starting to use it. But really, if you had a P low of 0, that patient would drop maybe to a PEEP of maybe 4 or 3. You just don't really know about that because you're cutting them off at 5. So in theory, you can do this. And I put this here as just really for completion, but it's not really commonly done. Probably most importantly is you want to look, is it the patient breathing spontaneously? So commonly, maybe the reason why the patient has respiratory acidosis is that they're breathing minimally or maybe not breathing at all. So you want to eliminate or decrease their sedation. And then in extreme cases here, if spontaneous breathing is not really working, you might want to change from the 6-second interval methods down to a 4 or 5 second method. So basically all this means is that now you're having more controlled breaths. And this is also on the protocol that you will find. So here, we're going to move on. And we're going to talk here about drop and stretch. And so our management here is first to wean the FiO2 down to 60%. Some centers use 50%. And when you first go on APRV, we're going to suggest here that you get blood gases approximately every 4 hours until the patient's stable, and then really maybe get them every 4 to 6 hours based upon your clinical judgment or your available resources. We're very cognizant that many centers could be overwhelmed with the number of COVID-19 respiratory failure patients they have, and so you need to take into consideration how frequently you can realistically get these blood gases. Next, you're going to decrease the P high by 1 or maybe 2 down to a target of 20 centimeters. So you're starting off at, say, 30, and you're going to decrease that P high after, again, you've decreased your FiO2 down to that 50 or 60%. Now, when you decrease your P high by 1 for every drop in 1 centimeters of water in P high, you increase the T high by 0.5 seconds. And this is what is referred to as that drop and stretch. So now for patients that might be rapidly improving, oftentimes we don't go down by 1 centimeter of water. We'll go down by 2, and we'll increase our T high time by 1 second. But again, since we've locked our T low time, we don't change the T high directly. What we do is we change the respiratory rate, and that changes the T high. And I have a video coming up in a short period here that'll illustrate what that means in a little bit more detail. So here's that particular video, and let's take a look at it. So for now, our patient here, we were able to come down to 60%, and we had actually started on 26/0. And now we're able to drop and stretch. And so how we would do that here is we'll open up our panel here for our settings. And what I'm going to do is I'm going to click my P high, and I'm going to come down by 2. And now in coming down by 2, for each 1 cc I come down, I want to increase by 0.5 seconds. And so from here, if I click on the time, I can see that the time high here is 5.5. And very importantly, I've locked it to the T low. So now I'm going to rotate this across here and increase my T high to approximately 6.5. And then I would set, and this is what the new settings would look like. So let me just review that one more time, because there's some important points. In most patients, when you set your T low, you already have that drop and you want to maintain that lung protective strategies. And so you're not going to change the T low. And that's why we recommend to lock the T low. So when you drop your pressures down as you're starting to wean someone off of APRV, then what you can do is you simply click the respiratory rate, and by turning down the respiratory rate, you automatically adjust the T high time. And that's an important point, because again, you want to make sure that that T low is locked in so you don't have excessive exhalation. So let's come back here to our talk and talk here a little about coming off of APRV. And so what we're going to recommend here is to come down to a P high of 20. And then once you get to a P high of 20, then you have a choice. If you're not as comfortable or familiar with APRV, when you're at a P high of 20, you can go to a conventional mode if you want and then wean from there. But what you'll find is that someone on a P high of 20 is able to go straight onto an SBT. And what we recommend is to go on an SBT of a PEEP of 10 with a pressure support of 10. And then to slowly wean those settings down to maybe something like 8/8 or so, or maybe 5/8. And then you can simply extubate straight from there. Since the patient was used to breathing really in a BiPAP format, we usually recommend extubate to BiPAP, maybe having an inspiratory pressure of 15/10 for expiratory pressures, and that usually does well. Now, if someone didn't do well in their SBT, then you just simply return them to their prior APRV settings. Now, alternatively, instead of dropping down to a pressure high of 20 and then going to a straight SBT from there, you might want to consider further decreasing individuals on their pressure high. I have some colleagues who lower individuals down to a P high all the way down to 10. And so basically at that point in time, they're on CPAP. They maybe have like 2 mandatory breaths in the whole cycle because they've dropped and stretched so much. And then you could just simply extubate straight off that P high of 10. And so that's a valid measure. And basically in a lot of our COVID-19 patients, by this time, they might have had a tracheostomy. And so if you think about dropping their pressure maybe all the way down to a pressure of 14 or 12 or 10 or something like that, really what you've basically done is just switch them over to high flow nasal cannula. Now, if you recall, when you have someone on, say, 60 liters or 80 liters high flow nasal cannula, what you're really having them on is CPAP. Because for every 10 liters of flow, it's approximately 1 of PEEP. And so on someone on 60 liters of high flow nasal cannula, they're really getting 6 of PEEP. And someone on 80 liters of high flow nasal cannula, they're really getting 8 of PEEP. But we can't go any higher than 8 on high flow nasal cannula. Well, if you had a tracheostomy or a tracheal tube or otherwise, here, now since you have more of a controlled airway, you can just dial in, say, that P high to 10 or to 12, and then basically just have that as CPAP the entire time. So we've seen high flow nasal cannula work exceptionally well in these particular patients. Here's a way to adapt APRV to really maybe thinking about it a different way, a higher order high flow nasal cannula or a CPAP mechanism, really just without the mask. They have either an endotracheal tube or a tracheostomy. So let's come back here to our PowerPoint. And here, I just want to illustrate in the graphic here that we came all the way down in this particular patient to a pressure of 20 over 0. They had a little difficulty with exhalation, and so we didn't drop and stretch. We didn't stretch as much, so they're still at that respiratory rate of 10. This particular individual actually started off at a mandatory cycle time of 4. So we did end up stretching, but since they started off at a cycle time of 4 instead of 6, that's why they look at 10 right now. We came all the way down to 60% for them, and they'd be able to go straight to a SBT straight from here, from this point. So additional notes here. If you happen to have some particular machines, then you're able to tell what someone's spontaneous ventilation is. Now, this is really important. When you first put someone on APRV, they need to be breathing, but they might not be breathing that much above the vent, again, because the pressures are so high above. But they might be breathing, say, 10%, maybe even all the way up to 30%. But it's important that they're breathing that much. And so certain machines will give you their spontaneous minute ventilation as compared to their controlled or total minute ventilation. And this number would be important for you to adjust your sedation accordingly. Now, if this information is not available to you on all ventilators, total minute ventilation is. And so when you're dialing them into a set respiratory rate and you see their drop cc per kilo, you can calculate what their machine-given ventilation is and just do the math to figure out what their spontaneous ventilation. But the takeaway point is that it's very important to know what their spontaneous minute ventilation is on this. Again, you'll start off at about 10 to 30, but then as you're coming down all the way down to a P high of, say, 20 or so, you want the patient to be breathing more, maybe anywhere from like 40 to 60% of the time as you come down. And that's what I talk about here. So as a refresher, again, I talked about here, initial target of maybe ventilation of 10 to 30 or so. As you're decreasing the P high and the patient's progressing, getting that minute ventilation spontaneous all the way up to 30 or 60% is more importantly. If the patient is having less effort than this, then you want to consider lightening the sedation to promote that spontaneous breathing. Conversely, if the patient is maybe breathing above that or they have excessive minute ventilation, maybe they're anxious or in pain or agitated or otherwise, you might want to increase sedation so that they're more comfortable. And this is just a reminder here that normal ventilation is approximately 6 to 8 liters per minute. Of course, in our patient population, when they're under some type of disease state, they could have a higher minute ventilation. But broadly speaking, since it's difficult to track end-tidal CO2 if you're not able to on APRV, you can look at minute ventilation instead. And so if their minute ventilation, say, is 4 liters or less, they're likely going to be hypercapnic. Or if their minute ventilation is greater than 12, the patient is likely anxious or in pain or otherwise, or they might have increased dead space ventilation and they might have pulmonary embolism, so it's something to think of too. But largely, again, concentrating on minute ventilation is important for sedation reasons and because it's so difficult to follow end-tidal CO2 on these patients as well. You can use that as a metric for how well they're doing in terms of their CO2. So here as a last slide, if someone requires a more mandatory minute ventilation, why would that be necessary? Well, you might have a patient that's doing well on APRV, but for some reason, even though they're breathing their 4 to 8 cc's and they have 10 or 30% spontaneous minute ventilation, for their particular physiology, they might need more mandatory ventilation. And so if they did, you can change them off of that 6-second interval cycle down to the 5 or 4, and that would give them more machine breaths and blow off more of that CO2. Thank you very much for attending this talk. Again, please visit our website and download our protocol that you will find. Thank you again.